the various questions here again. So over to Dr. Ravi Shankar.
Yeah, thank you, sir. It is a nice thing to talk about the most important topic, in the context of nursing, that is labs in the ICU and their relevances. Because day in and day out we do a lot of labs for some reason, sometimes without a reason, and we don't know how to interpret them and whether it is that was a rational step taken or not. So how do we interpret those labs is what we are going to discuss. And in this topic, I am going to discuss mostly about what are the most common tests which we do in the ICU and their interpretation, because it becomes very difficult to cover all the labs what we routinely do in the ICU. So here I begin with a case. This is a 65-year-old male who is a known case of diabetes, hypertension, coronary artery disease, and chronic kidney disease, COPD, with a history of recurrent urinary tract infections, who is presented to us with fever, burning micturition, and decreased urine output since 2 days, followed by drowsiness since 1 day. If you look at his medication history, he is a known diabetic who has been on oral hypoglycemic agents, that is metformin and glimepiride, and he's known hypertensive on telmisartan and hydrochlorothiazide, known coronary artery disease on aspirin, clopidogrel, and statin, known chronic kidney disease on diuretics, that is torsemide, and oral bicarbonate, that is Sobicis 4. And is also known chronic obstructive pulmonary disease on inhaler salbutamol and tablet acebrophilin. So does this really matter for us what medications he is on? Yes, it does have relevance to us, because not only the underlying condition what he is suffering, but also the medications what he is on do influence the tests what we are going to perform on the on the patient. So we need to have a detailed history as well as a medication history becomes very important. So coming to the examination, the patient was drowsy, he was arousable, and he was able to follow simple commands with a GCS of around 13 out of 15, that is E3, E4, and M6. He was hemodynamically borderline with a pulse rate of around 110 per minute and a blood pressure of 90/60. His respiratory rate was around 18 per minute and his room air saturation were around 94%. He was febrile, and systemic examination, cardiovascular system, there were no murmurs, and respiratory system, occasional wheeze was present posteriorly, and per-abdomen palpation revealed bilateral loin tenderness. So with this history, what would be your differential diagnosis? So anyone from the nursing want to answer?
Can anybody type it in the chat box, maybe 1 or 2 differential diagnoses, please? Somebody else, Jyoti wants to actually answer. Please, you can type it on the chat box, Ms. Jyoti. Okay, I think we're not getting the chat, but it's okay. Let's go ahead, Dr. Ravi. It's going to take some time.
So with this history and with this background comorbidities, the first differential diagnosis what anyone would think of is urinary tract infection. The second would be a patient who is a known CKD, who is presenting with a drowsiness with urinary tract infection. Obviously, you have to suspect acute kidney injury, acute renal failure. Then the other differential diagnosis, because he has been drowsy, so probability of aspiration needs to be considered because he is presenting with fever. The other differential diagnosis, patient being on oral hypoglycemic agents who is a known CKD, definitely the risk of hypoglycemia would be high with rise in creatinine. The other differential diagnosis would be hyponatremia, and any elderly with background coronary artery disease, with diabetes, hypertension, presenting with altered sensorium, definitely stroke has to be ruled out. And the other differential diagnosis with the COPD background would be chronic type 2 respiratory failure, that is CO2 narcosis. So what investigations would you advise in this patient? So the investigations, what you would be advising is, the basic routine investigations of CBP, hemogram.
Somebody.
Then the routine, yes, I am not able to see the chat box actually. So I'm trying to see what they are answering. Yeah, now I
Yeah, people have actually advised routine investigations, but routine investigations is a very too routine word. So I think probably let's be elaborate rather than let's be individually, go by system-wise approach. Somebody has advised a chest X-ray, somebody has advised an ABG, somebody has advised a HRCT, somebody has advised a renal profile. So I think most of them have covered completely. What are the other things? Probably Ravi, you can add some other things to that.
Yeah, I think most of the things you answered correctly. So the the CBP and the hemoglobin, because you are looking at infection, so you want to look at the counts, total leukocyte counts. The second is the renal function test because you are suspecting acute renal failure, and the routine liver function tests are not recommended in this patient. But because since we are going to discuss in this patient, I am going to talk about why we do liver function test in this patient. Then the other would be coagulation profile. Obviously, patient being hospitalized, you want to start him on anticoagulation. You have to look at the baseline coagulation status before initiating any anticoagulation. And CU urine cultures, obviously, because you want to rule out infection, so you do a complete urine analysis. Subsequently, you want to send urine cultures to rule out infection. Then blood cultures, again, to rule out any blood infection. Then a chest X-ray, ABG, he being a COPD patient, and you're suspecting CO2 narcosis with aspiration, you want to look at whether there is any aspiration pneumonia, and you want to do an ABG to look for any metabolic acidosis, or you want to look at CO2 narcosis. Then to rule out stroke, you want to do a CT brain, and then a ECG, keep being an hypertensive with the CAD, again presenting with after sensorium. Sometimes you do miss arrhythmias, and it is mandatory to do ECG at the time of admission to all patients. So what are the relevant investigations? See, this is what we have seen earlier. So these are the investigations which you have done in the context of the clinical condition. But sometimes a patient presenting to the hospital, there are, some, if you look at his comorbid history, so he has got multiple comorbidities. In the context of comorbidities, you sometimes end up doing relevant investigation in the context of the disease itself. For example, patient who is known diabetic, you want to look at his fasting sugars, postprandial sugars, what is his average glucose control by looking at HbA1c value. Then to rule out any infection which is very common in diabetics, you want to do a complete urine analysis, look at proteinuria, and because diabetics are more prone to acute kidney injury and CKD, so you want to look at serum creatinine. Again, silent MIs are very common in these patients. You want to have a ECG. Then the other is background hypertension. You want to look at whether his hypertension is under control. You want to look at features of left ventricular hypertrophy on the ECG, strain patterns. So these things you'll be able to make out by looking at the ECG and the baseline 2D echo to detect for any underlying cardiac dysfunction. Again, the same thing, the coronary artery disease history also will make us do workup for the 2D echo. Then a patient who is a known chronic kidney disease, you want to look at his creatinine, what was his baseline creatinine, whether the creatinine increased from his baseline, and does he have any proteinuria, and if he has a proteinuria, whether is it significant or not, is it nephrotic range proteinuria. So all these things you want to look at by doing urine protein creatinine ratio. Then COPD, as we have looked earlier, also you want to look at any changes of RA, RV, hypertrophy. So you want to look at by looking at ECG changes of P male and right axis deviation, and you want to look at what is this any emphysematous changes on the X-ray, and you want to look at consolidation changes. So all these things can be made out by doing an X-ray. And a baseline ABG, whether he's a chronic CO2 retainer or whatever, what is his baseline CO2, all these things can be looked upon by doing a baseline ABG. And as we have discussed, urinary tract infections, you want to do, send a urine and blood cultures. And again, you want to rule out any pyelonephritis, you end up doing either an ultrasound abdomen or a CT scan abdomen. So what I want to stress here is you have to understand the background, what is the presenting condition, and based on that, you have to advise the investigations. So again, when you send a multiple tests without knowing why you are sending, you don't know what to interpret. So it is always when you come to the interpretation of the data, it is very important to interpret in the context of the clinical condition. And the tests what we are going to do are not only going to help us in the form of screening for detecting early changes like diabetes presenting with the diabetic nephropathy, but also in the diagnosis of the patient and also in the monitoring of the clinical condition throughout his stay during the hospital. And you also have to be very much familiar with the relevant tests and what is the normal values and how do you interpret them. Because if you look at, there are some tests which have variable intervals, like reference interval varies when they are at normal health and when they are at disease. When you are looking at more specific like hormonal levels, so they change depending on the disease. Diurnal variation will be there. So these biological variations can lead to false interpretation, which you have to be very much aware of. And you also need to know the sensitivity and the specificity of the specific diagnostic test what you are asking for. And one of the most important thing which I want to stress here is the errors. Errors are very common in the ICU, and if you look at the errors, there are multiple ways an error can happen when you are doing and sending a lab. For example, if you collect the sample in a wrong Accutaner, or you have collected in the wrong Accutaner and transferred the sample to another Accutaner after realizing that you have done wrong, or if you have delayed in sending the lab, or if you have the sample is clotted. Sometimes you end up receiving calls from the lab saying that the sample is clotted, so you redo the sample. See, at the end of the day, what we are doing is you are sampling the patient multiple times, which is going to which is not comfortable for the patient, as well as you are drawing more and more amount of blood daily. If you look at the studies, average amount of blood what you are drawing per day in the ICU is close to 41 ml per day, which is very, very, very significant. And you also need to understand that there are lot of lab to lab variations when it comes to the reference ranges. So when you are interpreting a lab parameter which was done outside, you have to know the reference value of the lab from where it was done. Unless then you cannot interpret the value appropriately. So this is very important when you are interpreting the data. Now we will come to each individual test, what we are going to do and how are we going to interpret those tests. The first and the foremost is the complete blood picture or the hemogram. So if anyone can tell me what is the difference between a complete blood picture and hemogram, because sometimes I write CBP, sometimes I write hemogram. So is there really any difference between CBP and hemogram? Anyone wants to answer that question? Okay. Basically, hemogram will look at ESR is included in the hemogram, and you are going to look at the peripheral smear. Complete picture will give only your lineage, that is whatever the red blood cell lineage, white blood cell lineage, and the platelet series. So the CBP includes your hemoglobin, your packed cell volume or the hematocrit, and your total leukocyte count and the differential count and the platelets. So if you look at CBC is one of the most commonly or the routinely performed blood tests in the ICU. It detects many of the blood diseases and disorders, like you want to look at anemia, thrombocytopenia, you want to look at infections or any presence of abnormal cells within the look in the peripheral smear. So what you do here is you collect a peripheral venous blood, which is collected in the lavender tube. Basically, this tube is coated with EDTA so that it doesn't distort the morphology of the cells, because most of the times what we are doing is an automated analyzer. Basically, these automated analyzers will, based on the size of the cells, they differentiate the counts and will give you a value. There are 3-part analyzers, 5-part analyzers, and 7-part analyzers. Depending on the your lab equipment, it will change actually the way you are looking at the CBC. And once the sample is collected in the lavender tube, it should be thoroughly mixed and it should be immediately sent to the lab. So any clotted sample or any preserved sample is not an acceptable specimen when you're doing CBC. And as I told, the methodology of testing is via the whole blood analyzer. So if you look at, as I said, there are different parameters what we are going to look at in this. First is the red blood cells, and the red blood cells normal count is around 4.3 to 5.9, which is slightly higher in the males compared to females, which is around 3.5 to 5. So if you look at the red blood cells, there can be either a deficiency of the RBC, where the RBC can be low, or the RBC count can be high. So if the RBC count is low, that means you have anemia. So it can be because of multiple reasons. The most common is the patient might be having anemia because of low RBC count. It could be hemolytic anemia, non-hemolytic anemia. There are multiple causes of this anemia. And one of the most common cause of anemia in the traumatic setting is acute bleeding, or patients with congenital disorders, hereditary disorders like thalassemia, sickle cell disorders, spirocytosis. All these will again cause anemia with low red blood cell count. On the contrary, you also tend to see the higher RBC counts, which is called polycythemia. This polycythemia is nothing but when you have a higher RBC count, it could be either a primary polycythemia or a secondary polycythemia. The primary polycythemia is basically overproduction of the red blood cells by the bone marrow because of underlying disorder, mutation, or any other reason. A secondary polycythemia is generally seen whenever there is a hypoxia. This hypoxia will stimulate the marrow to produce more number of red blood cells to deliver more oxygen, and this creates a polycythemia. So this is seen in patients who are chronic smokers, patients who have traveled to high altitude, or a patient with congenital heart disease where there is mixing of the venous blood with the arterial and low oxygen levels. So chronically, so these patients do have polycythemia, where if you look at their CBC, their hemoglobin count will be somewhere around 17, 18, 19, and your RBC counts will also tend to be on the higher side. So if you look at the causes of anemia, there are multiple causes of anemia, either be it the production defects where there is a bone marrow problem, or a patient with a CKD where there is an erythropoietin deficiency, or the survival defects or a maturation defect, which are sometimes most of the congenital, like hemolytic anemia, autoimmune hemolytic, spirocytosis, thalassemia, where there will be destruction of the cells, or any patient who has a splenomegaly, so where the sequestration happens in the spleen, and any patient who has an acute blood loss in the form of trauma, or patient is losing blood from somewhere else, like GI bleed is very common in our ICU setting. So again, one of the other parameter what you look at when you are evaluating for anemia is your hemoglobin. Hemoglobin normal value in males is around 14 to 18. In the females, it is around 12 to 16 grams per deciliter. So if you classify the anemia based on the morphology, so morphological anemia can be classified into microcytic, normocytic, and macrocytic based on the size of the cell. If the size of the RBC is very small, it is called microcytic. If it is very large, it is called macrocytic. So if the hemoglobin levels are decreased, if the RBC size is normal, it is called normocytic because the cells are still normal in size. So it happens whenever there is an acute blood loss, so where you are rapidly losing blood. So you still have anemia, but it is normocytic RBC. On the other hand, patients with chronic kidney disease, where the production itself is hampered, so you end up seeing normocytic anemia. Then the other is a microcytic anemia, which is the most common cause of microcytic anemia is iron deficiency anemia. The other spectrum is the macrocytic anemia, where if you look at the MCV, it is on the higher side. The most common cause of macrocytic anemia is vitamin B12 or vitamin folic acid deficiency. Alcoholics, hypothyroids do end up having macrocytic anemia. The other is abnormal cells within the peripheral smear, that is sickling. That is called sickle cells, where there is a abnormal hemoglobin structure itself, which is a HbS hemoglobin, where it leads to whenever there is a hypoxic setting or an infection setting, the RBC, which are supposed to be biconcave, will turn into sickle cells. Like you see sickle, it is the RBC will form, like if you look at it, they're in the shape of a sickle. And another important parameter what you are going to look at in the CBC is the hematocrit. Hematocrit is nothing but if you separate the cellular component and if you separate the fluid component, so the cellular component consists of two parts, that is the red blood cells, the white blood cells. The white blood cells are very less in number. So usually the PCV or the RBCs form the predominant part of the hematocrit. So it will indirectly tell whether the patient is having anemia or not. So any patient who is having anemia will usually have a lower PCV value. On the other side, if the patient is grossly dehydrated also, it can lead to high hematocrit because of the relatively lower fluid component compared to the cellular component. So this is the morphological classification of anemia, what I was talking about. The normocytic, where the MCV is between 80 to 100, and microcytic, where the MCV is less than 80, and the macrocytic anemia, where the MCV goes more than 100. And this is the hematocrit what I was talking about. So if you centrifuge the blood sample, you will get the plasma component, which consists of water, your proteins, all this will collect at the top, and your cellular component, which is dense, will collect at the bottom of the sample collection tube. So usually red blood cells will be the lowermost portion of the tube, and this constitutes the hematocrit. So whenever there is anemia, so if you look at the RBC count is low, so relatively the hematocrit is falling. On the other side, if you look at, you can have high hematocrit, especially if they're dehydrated because of the lower water content compared to the cellular content. Then the second component, what you are looking at is the white blood cells. Again, white blood cells normal count is around 4,000 to 11,000 cells. And the normal, that if you look at the differential count, there are different components of the white blood cells, including your neutrophils, eosinophils, basophils, lymphocytes, and monocytes. For us, what is important here is neutrophils, lymphocytes, and eosinophils. Usually, there, if you look at the normal values, the predominant component is the neutrophils, that is around 2,500 to 7,500 cells. And the next, the most important is the lymphocytes, which constitute around 3,000. And third is the monocytes and the eosinophils. So any deficiency of the white blood cells or the decrease in the number of white blood cells is called leukopenia as such for the whole group. And individually, if you look at if isolated neutrophil deficiency is there, it is called neutropenia, lymphopenia, or monocytopenia. And there are multiple causes for neutropenia, like patients who had aplastic anemia or myelodysplastic disorders, patients who have undergone chemotherapy. All these patients will have lower neutrophil count. And again, lymphocytopenia or lymphopenia is also very commonly seen in the ICU setting, especially in the viral infections or connective tissue disorders like systemic lupus erythematosus, rheumatoid arthritis. And the other is the elevation in the white blood cell count, again, which is very commonly seen in the ICU, that is called leukocytosis, when the counts are going more than 11,000 per cubic millimeter. So neutrophilic leukocytosis, when there is absolute increase in the amount of neutrophils. And eosinophilia, especially you see very commonly in the setting of parasitic infections or fungal diseases or allergic disorders or skin disorders. So you end up seeing eosinophilia. And there are other causes of monocytosis like Langerhans cell histiocytosis, sarcoidosis, or autoimmune disorders do cause monocytosis. So you can look at the leukocytosis as a whole. It is an indication of infection most common, or you can look at the individual component, which component of the leukocytes are increasing specifically, and that will help us in giving a clue what exact pathophysiology is happening with the patient. Then the next is the platelet count. The normal platelet count is somewhere between 150,000 to 450,000. Again, this is normal for all normal individuals, but some patients do have a lower baseline platelet counts, and you have to essentially ask them if they have ever done their platelet counts. Their baseline platelet count may be lower side for some patients, and those patients you need to work up separately. So any deficiency of the platelets is called thrombocytopenia, where the platelet counts go less than 150,000. And any elevation in the platelets is called thrombocytosis, where the platelets increase, which can be because of multiple reasons, like sudden blood loss can cause reactionary thrombocytosis. Normally, platelets are sequestrated in the spleen or destroyed in the spleen, and when the patient has gone splenectomy, you end up seeing those patients having higher number of platelet counts. And any patients having connective tissue disorders again can have higher platelet counts. If you look at the causes of thrombocytopenia, there are multiple causes of thrombocytopenia in the ICU. There is immune-mediated destruction, non-immune-mediated destruction, or decreased production itself. So if you look at the decreased production, basically the problem lies within the marrow, either because of the bone marrow failure like aplastic anemia, myelodysplasia, or radiation-induced damage, chemotherapy-induced, hematological malignancies, human immunodeficiency virus infection, and all this marrow infiltration because of secondary malignancy infiltration, or vitamin B12 and folate deficiency also do present with thrombocytopenia. And if you look at the destruction, increased destruction of the platelets, if it is immune-mediated destruction, the most common what we see is ITP or heparin-induced thrombocytopenia with the more increased use of heparin in the ICUs, especially cardiac and cardiothoracic ICUs. We see HIT, which is a specific entity, and post-transfusion purpura or connective tissue disorders also do cause ITP, secondary ITPs. And non-immune mediated destruction, especially patients who are in DIs, where it is a consumption coagulopathy, where the platelets are consumed. And thrombotic purpuras like PTP, HUS can also do present with thrombocytopenia. The next is the coagulation profile, what we routinely do in our ICU. Again, coagulation profile is very important. Basically, we are looking at couple of parameters. One is the prothrombin time, the activated partial thromboplastin time. Some labs, some ICUs do practice doing thrombin time, D-dimer also. But basically, the most important what we are concentrating here is the PT, APTT, and the fibrinogen level. If you look at prothrombin, prothrombin is one of the protein produced by the liver, which is very essential for your clot formation. And by doing a prothrombin test, basically you're looking at the extrinsic pathway. As you're all aware, the coagulation pathway has two pathways, that is the intrinsic pathway and the extrinsic pathway. The extrinsic pathway is monitored by looking at a PT, prothrombin time, and the intrinsic pathway is monitored by doing APTT. Normal value of the prothrombin time is around 10 to 15 seconds, and it can be prolonged because of multiple reasons, like patient is on blood thinners, be it warfarin, or patients with hemophilia, patients with liver disease, patients who have malabsorption syndrome, which is vitamin K dependent factors underproduction in the liver, which can lead to prolonged PT. And this is also routinely done for all patients who are on anticoagulation, especially warfarin or coumarin derivative anticoagulation. For those patients, you routinely do PT-INR to monitor the coagulation status. And the other test, what you look at is the activated partial thromboplastin time, that is looking at the intrinsic pathway. So factor 7 and activation via the factor 10 to factor 10A is by the PT, and other factors, factor 13, 12, 11, all these factors are looked at by looking at the intrinsic pathway. Another important coagulation factor what you are looking at is the fibrinogen. Again, fibrinogen, one of the protein which is synthesized by the liver, and fibrinogen is essentially consumed whenever there is a clot formation. So whenever there is an extensive bleeding or hemorrhage or hyperfibrinolysis state, or in pregnancy in the context like abruptio placenta, you end up seeing hypofibronemia. If you look at normal fibrinogen levels, it is around 180 to 350. Less than 180, it becomes significant. So this is the coagulation pathway what I'm trying to look at. This is the intrinsic pathway where you are looking at 11, 8, and activation of the prothrombin to thrombin. So you're looking at APTT. The other is extrinsic pathway where factor 7 is activating the factor 10 to 10A, then again prothrombin to thrombin. And the thrombin time is basically looking at fibrinogen conversion to fibrin monomer to fibrin polymer. Then this is the normal value. Prothrombin time is normally around 10 to 12 or 10 to 13. The INR ratio, you compare the test to control, normal value is around 0.8 to 1.2, and activated partial thromboplastin time is normally between 23 to 32. So then other is a renal function test. What you are going to look at is the blood urea nitrogen. Blood urea nitrogen is nothing but end product of protein metabolism, which is happening in the liver. It travels through the body and excreted by the kidney. And you can either look at blood urea per se or blood urea nitrogen. Some labs do blood urea, some labs do blood urea nitrogen. Blood urea nitrogen measures the amount of nitrogen in the blood in the form of urea. If you look at the normal value, it is around 6 to 20, and in elderly, it may be slightly higher. And whenever the blood urea is elevated, you call it as azotemia because of retention of the nitrogenous waste products. There are multiple causes of this azotemia. Either it could be pre-renal causes like dehydration, shock, excessive production. Renal azotemia, the pathophysiology is in the renal disease itself, like glomerulonephritis, pyelonephritis. All these will cause renal azotemia, or post-renal like obstructive uropathy because of stones, tumors, or prostatic obstructions. Then the other parameter what you are looking at is serum creatinine. Basically, it is because of the breakdown of muscle creatinine phosphate, and it is excreted by usually glomerular filtration, tubular secretion, And why it is important is usually any increase in the serum creatinine, it is telling that the glomerular filtration rate is falling down. That means the kidney is under functioning. So if you look at the normal value, in the men it is around 0.6 to 1.2, whereas in the women it is slightly on the lower side, 0.4 to 1 milligrams per deciliter. So there are different causes of elevated serum creatinine, like if you consume excess meat, or if you do a heavy strenuous exercise, or if you have a renal pathology like pre-renal, intrinsic or extrinsic, post-renal causes of renal failure, all these will cause serum creatinine. And paradoxically, serum creatinine will be slightly on the lower side in the pregnancy. So I want to ask, what is the best marker if you are looking at, acute kidney injury? Either you want to look at blood urea, you want to look at, serum creatinine, you want to look at blood urea nitrogen, or you want to look at eGFR. What is the best parameter here when you are considering as a marker for AKI? Very good. Somebody, I think,
answered as eGFR.
Yeah. Yes. That's a right answer actually. Basically, because urea and blood urea nitrogen can be elevated because of multiple reasons, as we have said earlier, because of excess consumption of meat, exercise, all this can cause, or GI bleed can cause elevation of urea. And sometimes when the acute kidney injury is setting up, the creatinine will take slightly, more time for it to get elevated. Maybe we may be, delayed in detecting the acute kidney injury. If you are able to calculate the eGFR, again, which is based on the calculation, there are two ways of looking at GFR, whether you are calculating directly or based on estimated creatinine, eGFR will give you a better picture of, AK. Now, there are other novel markers which some labs are doing, which will help us in early identification of the AK. So if you look at, there are two parameters, that is a GFR, that is glomerular filtration rate, and the other is the creatinine clearance. GFR is nothing but the volume of water either filtered or cleared out of the plasma per minute at the renal level. So how do you calculate GFR? GFR is calculated laboratory by urine excretion of a marker. Like you can look at inulin clearance, which is an ideal substance to look at, or you can have urinary creatinine, serum creatinine, and based on it you can calculate the GFR. If you look at the GFR, normal value is around 120 ml per minute per 1.73 meters square. That is body surface area. And most of the labs, when you do the renal function test, will give an eGFR, which is an estimated GFR based on the age, weight, creatinine. Based on this, it will give an estimated GFR, which closely correlates to the calculated GFR. If the GFR is going down, that means the kidney function is going down. So you can either look at GFR, or indirectly you can also calculate something called creatinine clearance, which is nothing but the rate at which creatinine is removed from the blood. It is also indirectly giving you an estimation of the GFR. So either you can do GFR or you can use creatinine clearance. So basically, creatinine clearance is looking at the excretory capacity of the kidney. So if you want to calculate the creatinine clearance, there is some formula which is called Cockcroft-Gault formula, which is a standard formula used in the ICUs, which includes your age, your lean body weight, serum creatinine, and based on that you can calculate the creatinine clearance. Okay. So why it is important is, if you look at, you can classify the staging of the kidney disease, okay, based on your GFR or your creatinine clearance. If you look at all your glomerular filtration rate as well as the creatinine clearance are almost correlating, whereas your creatinine may sometimes take time to elevate, so it may have a delayed presentation. So based on these categories, you can classify the CKD stages into stage 1, stage 2, stage 3, and when it goes less than creatinine clearance less than 10, it becomes very significant because the kidneys are completely failed. And again, your antibiotic dosing is again modified based on your creatinine clearance in the ICU. Then you look at the renal parameters, other electrolytes like sodium, potassium, which we commonly do. Sodium is a major cation which is predominantly present in the extracellular fluid. Normal value is around 135 to 145, and it is predominant functions are look at the maintaining the serum osmolarity, water balance, and ion shifts. And you see hypernatremia when the extracellular sodium goes more than 145. We call it as hypernatremia. There are multiple causes for this hypernatremia, like excessive dehydration, or sodium load, like you give sodium bicarbonate to the patient, so invariably end up having hypernatremia, or 3% saline. So it causes hypernatremia. And the most common setting which we see hypernatremia is, diabetes insipidus or diabetic ketoacidosis. But the hypernatremia, what you see in diabetic ketoacidosis is different, because you have to do the correction for the glucose. Based on that only you have to calculate the sodium. Then the other syndrome is a Cushing syndrome, which can again present with hypernatremia. If you look at the clinical features, patient can present with altered sensorium, weakness, irritability, sometimes with coma and seizures. So ideally, if you want to correct the hypernatremia, obviously you have to calculate the free water deficit, and you should not correct it very rapidly. You have to correct it at least 0.5 to 1 milliequivalent per hour, or at a range of around 8 to 10 milliequivalents per day. Then the other spectrum is hyponatremia, where the sodium is less than 130 milliequivalents per deciliter, and the causes are including excess water consumption, or decreased fluid excretion, or increased salt losses via kidney. And patients with hepatic failure, acute renal failure, congestive cardiac failure, all these patients do end up having hyponatremia. SIDH is one of the very common presentation in the ICU to cause hyponatremia. And patients whoever are on thiazide diuretics can do present with hyponatremia, which is again one of the most common cause of hyponatremia in the ICU. Again, hyponatremia can present with nausea, vomiting, headache, lethargy, slowness, seizures, cerebral edema, and coma. The correction is, because the sodium load is low, you have to correct either the sodium by giving 3% saline, or you have to restrict the fluids, especially in case of SIDH, and you can use Vaptans in case of congestive cardiac failure or hepatic failure. You can use tolvaptan. Another electrolyte which is very important for us is the potassium, which is a major intracellular cation. The normal value is around 3.5 to 5.5 milliequivalents per deciliter. The muscle it is very important for the muscle contraction, fluid balance, and nerve transmission. And if you look at it, has got the inverse relationship with the pH. As the pH goes high, the potassium level falls, and as the pH level goes low, the potassium increases. So the hyperkalemia is when the potassium goes more than 5.5. The most common cause of hyperkalemia are renal failure, metabolic acidosis, excess intake of potassium via the oral Kesol syrups or IV correction, rhabdomyolysis, patients with Addison's disease. The clinical features of hyperkalemia include your weakness, fatigue, paresthesia, respiratory failure, and ECG changes. And the treatment is with diuretics, which cause elimination of the potassium via the urine, and by transcellular shifts by using your aspirin or insulin with glucose. All this will cause intracellular shift of the potassium from ECF to intracellular fluid, and membrane stabilizing agents to prevent arrhythmias include your calcium gluconate and bicarbonate, and oral potassium binders like your capsulate like K-bind, which will be given orally, so which will decrease the absorption of the potassium from the gut. Then hypokalemia, when the potassium goes less than 3.5 milliequivalents per deciliter, the most common causes are GI losses, like either in the form of diarrhea and vomiting, you end up losing potassium. Renal losses with excessive use of diuretics in patients with cirrhosis, congestive heart failure, so you invariably see hypokalemia. Patients who have got alkalosis, metabolic alkalosis, as I said, pH is elevated, the potassium goes low. So potassium will be shifted to the intracellular. So this will cause shift of the potassium and cause hypokalemia. And if you look at the clinical features, again, hypokalemia can present with fatigue, weakness, paralysis, respiratory depression, and constipation. And if you look at the ECG changes, hyperkalemia can cause hyperacute T waves, sine wave pattern, arrhythmias, cardiac arrest, VTVF, whereas hypokalemia can present with U waves and flattened T waves. And because potassium is low, you correct the potassium whether by a oral route or by intravenous route. Then the other important electrolytes include your calcium, which we commonly do. The normal value is around 8.5 to 10.5 milliequivalents per deciliter. It is the most abundant mineral in the body. It is very important for bone formation, as well as it is very important in the formation of clot. It is one of the clotting factors. So if you look at, there is normal calcium, there is ionized calcium. So ionized calcium is important because if you look at 50% of the calcium is bound to albumin. So 50% of the calcium remains free. That is what we are checking. That is ionized calcium. The normal value would be somewhere around 4.5 to 5.5 milligrams per deciliter, or 1.1 to 1.3 millimoles per liter. So if you look at total calcium, sometimes it may be normal. But if you look at albumin is low, then the calcium may be on the higher side. If the albumin is high, the free calcium may be on the lower side. So you have to look at both the ionized calcium and the total calcium. And when you are working up for the calcium, it is very important for us to look at the vitamin D and the parathyroid hormone levels also. Hypercalcemia, when the calcium goes more than 10.5 milliequivalents, the most common causes are hyperparathyroidism or malignancy, Patients do present with depression, weakness, fatigue, confusion, hypotonia, seizures. And treatment is with saline, first saline hydration, or you can attempt saline diuresis and loop diuretics, which will cause elimination of the calcium by the urine. And hypocalcemia, when the potassium goes, when the calcium goes less than 8.5 milliequivalents per deciliter. The causes include your hypoparathyroidism, post-thyroid surgery where accidentally parathyroid might have been removed, tumor lysis syndrome, or hypomagnesemia. The clinical features are, paresthesia, cramps, hyperreflexia, tetany, and carpopedal spasms and seizures. The treatment is either with calcium gluconate or calcium chloride as temporary measure, and subsequently start on oral calcium supplementation. And other trace elements which are very important for us are the phosphorus and the magnesium. The normal value of the phosphorus is around 3 to 4.5 milligrams per deciliter. It has got very important role in muscle contraction and ATP. Hyperphosphatemia happens whenever there is renal failure, liver disease, hypoparathyroidism, hypercalcemia. And hypophosphatemia, which is very commonly seen in the ICU, happens because of malnutrition or refeeding syndrome, or whenever there is hypercalcemia or hyperparathyroidism, or patients who are chronic alcoholics, they end up having hypophosphatemia. Magnesium, again, the normal value of magnesium is between 1.5 to 2 milligrams per deciliter. It has got significant role in ion shifts, and hypermagnesemia can happen because of renal failure or iatrogenic when you're infusing magnesium for some other reason, like you're giving magnesium for eclampsia. Or the clinical features include your weakness, paralysis, drowsiness, confusion, reflexia, and bradycardia. And the treatment of magnesium is calcium is one of the antagonists for magnesium. So you give calcium to neutralize the effect of the magnesium, or if it is refractory, then you end up doing dialysis. Then the other is the hypomagnesemia, which is because of decreased absorption, chronic alcohol history, or increased losses via the gut. So clinical manifestations include your fasciculations, something it presents like hypocalcemia. So tetany, ataxia, seizures, and arrhythmia. The classical arrhythmia which you see with hypomagnesemia is the torsades beat point, which is mimicking your beating. Then the correction of hypokalemia is very important whenever you are correcting hypomagnesemia. Then the other important parameter in the context of renal function test is your complete urine analysis. You get multiple parameters in the complete urine analysis. You look at the volume, whether the patient is having low concentrated urine or polyuric. You also look at the color. Color depends on the hydration status of the patient. If it is very pale, then it is patient is probably polyuric, passing low osmolar urine. Or if it is very concentrated amber colored urine, probably patient is very much dehydrated. That's why it's passing amber colored urine. Normal smell is something like aromatic volatile oil smell, but sometimes patients with urinary tract infections do have foul smelling urine, and patients with metabolic disorders sometimes have burnt sugar smell. So these are different things which you look at in the CUE. The specific gravity, again, it looks at the concentrating ability of the urine, whether the urine is concentrated or hypo istinuria, or all these things you are looking at. And you also look at the pH of the urine. The normal pH of the urine is between 4.6 to 8. Sometimes you may be passing alkaline urine when you are using bicarbonate therapy. So you end up seeing urine pH more than 9. And you also look at other important parameters like protein, whether the protein is losing in the urine. They give in the form of albumin 1+, 2+, 3+, and especially in the pregnancy, for us to diagnose, eclampsia, preeclampsia, you need to look at the protein elimination in the CUE. And you also look at sugar in the urine, especially in the diabetics, and also ketones. Ketones can be positive because of multiple reasons like starvation, decay, and hyperemesis gravidarum can cause ketones in the urine. And you also look at pus cells or leukocyte, which is indicative of infection. Some CUE laboratories will give leukocyte esterase, which is will tell you that there is a urinary tract infection. And you also look at bile salts and bile pigments in the context of any patient with deranged hyperbilirubinemia can have bile salts and bile pigments excreted in the urine. And also there are CAS in the form of iline, white blood cell, or red blood cell CAS. In different situations, you will see different CAS. Then the other is the liver function test. The liver function test, basically broadly you can look at the liver function test into many categories. Test based on excretory function, whether bile excretion, whether it is correct, how much the liver is functioning, or test based on the serum enzymes which are released from the liver like AST, ALT, gamma glutamyl transpeptidase, or test based on the metabolic capacity, which we don't do normally, test based on the synthetic function of the liver, that is your prothrombin time and serum albumin, and test based on the detoxification, which again you are not going to do routine in the ICU. So if you look at the bilirubin, the normal bilirubin value is around 0.2 to 0.8. In that, the unconjugated bilirubin is around 0.2 to 0.6, and conjugated is around 0.0 to 0.2. So if the plasma bilirubin exceeds 1 milligram per deciliter, it is called hyperbilirubinemia. And once it crosses more than 2 milligrams per deciliter, this excess bilirubin will creep into different tissues and will cause yellowish discoloration of the urine, sclera, mucous membranes, and we typically see, we call it as icteric. Okay, so the patient is having jaundice. So this basically bilirubin is produced as a byproduct of metabolism of heme metabolism, and this is supposed to be eliminated either via the urine or via the stool. And whenever there is, this unconjugated bilirubin conjugation happens in the liver, and that doesn't happen, it leads to hyperbilirubinemia. Whenever the indirect bilirubin is increasing compared to direct bilirubin, we call it as hemolytic jaundice. And when the direct bilirubin is more, you call it as obstructive jaundice. And when you see both, it is usually damage is at the level of hepatocellular level. And you also end up seeing bilirubin in the urine whenever there is hyperbilirubinemia. So usually it is a conjugated bilirubin which is being water soluble, which is excreted in the urine, not the unconjugated bilirubin. So the other enzymes what you are looking as a part and parcel of the LFT is your AST and the ALT. AST is also called SGOT, that is serum glutamate oxaloacetate transaminase. The normal range is around 10 to 45, and AST is predominantly found in cytoplasm and mitochondria. And if you look at AST and ALT is more specific for liver damage and compared to the AST. And ALT is also called serum glutamate pyruvate transferase. There are multiple conditions which can cause elevation of AST and ALT, like alcoholic liver hepatitis, drugs, all these can cause. And alkaline phosphatase is again one of the enzymes which you are looking at when you are looking at the biliary obstruction. Then albumin is a predominant protein which is inside the liver. The half-life is around 20 to 25 days. It is usually an indicator of chronic liver damage rather than acute liver damage. And low serum albumin is also seen in malnutrition. And you invariably see a reversal of albumin-globulin ratio. So I'll skip this X-ray and the ABG in view of lack of time. I'll take to the questions actually. So I'll give you two questions. Okay. So what are the most common cause of metabolic acidosis in the ICU setting? Unfortunately, I did not cover this
for some time. Yeah, we'll just wait for some time. Let them ask questions.
Yeah. Yes, sir. So if anyone have your questions, we are ready to answer that question.
No, I was just telling about let them answer. Please, anybody can answer this particular question, causes of metabolic acidosis.
Okay, somebody has answered DKA. Again, I think everyone answered DKA.
Only DKA is the answer.
Yes. So this question is misleading actually. I want...
Anybody would like to answer anything? Or would like to speak about on the forum?
Surya Padma. Yes. I think one of them has answered, sir. I think all is correct actually, because DKA can cause, acute renal failure can cause, shock can cause, acute gastroenteritis can cause. I did not give the option E, which is all of the above deliberately, because I want to know whether you are looking at each parameter or not. Good. Then I'll take you to the next question. So a patient is admitted to the ICU with severe respiratory distress. His secondary diagnosis is acute lymphocytic leukemia, and is you have done his CBC, and his CBC has shown that hemoglobin is 8, total counts of around 20,000, out of which 50% are band forms. Sorry, 50% are segmented neutrophils. Band forms are 7%. Eosinophils are 5%. Basophils are 0.5. So anyone knows how to calculate the absolute neutrophil count? Because here absolute neutrophil count becomes very important for us, especially patients who have undergone chemotherapy or underlying malignancy where you want to isolate them.
If anybody wants to speak, can as well raise their hand so that we would allow them to talk and give the answer for an explanation. It seems to be a very simple answer, but it's very commonly we see this.
Sometimes you do get the ANC value in the lab value itself, but if you, in case if you don't have that, you should be ready to calculate the ANC value. So the reason for putting this question is that
somebody is
so which one you want me to choose? C or D?
I'll take up this answer. Okay, Dr. Ravi.
Sure.
See, thing is, see, why do you require an absolute neutrophilic count for any patient having probably febrile neutropenia? You need to isolate these patients, otherwise they are prone for infections. So maybe you get the lab value in the morning, the doctor is not seeing the value still. So, but then you need to know this. So how do you calculate? Okay, it is total leukocyte count is 2000. So the segmented neutrophils are 50%. So it should be 1000, right? But again, band forms are also there. It indicates sepsis, and segmented neutrophils with band forms are 7%. So you need to add that 7% more. So the answer is 1000 plus 140 for 7% of 2000. So it is 1140 is the answer. If everybody has listened to the Dr. Ravi's session very well, I think they could have answered this, because he has clearly explained you need to know about all this, what would be the normal percentage and all these things. So let's go to the next question, please.
An elderly patient is admitted in the ward with fever and presents to the ICU with altered sensorium, and his baseline parameters are like serum sodium is 110, potassium is 4, chloride is 104, blood urea nitrogen is 28, and creatinine is 1 milligrams per deciliter. The patient is drowsy because of I think Surya Padma, Sarika, Upin, and Nisha, Athiramur. Okay. So all of you are right. For uremia, 2 people have answered uremia. So I want to ask them, why do you think it is uremia? So what is the normal blood urea nitrogen level? So question number 1.
So this is a very common question everybody comes across. So what would be the normal BUN values? So the nursing staff would be definitely knowing all these things. Okay, they would be telling, okay, the BUN value is high, patient maybe are drowsy because of this, or might require dialysis because the urea levels are very high. So the answer here is, if you see the normal values for BUN, which are ranging around 40, it is like 20 to 40, it is not that high. So it is within the normal limits. The only thing which is abnormal in the electrolytes is the sodium levels. And in elderly patients, especially who's been admitted to the hospitals, it is very common that they tend to have some sort of electrolyte abnormalities. That is, hypernatremia is a very common electrolyte abnormalities, which we all need to know in and out, because they'll be very drowsy. We will be thinking a lot of things. There might be some stroke or something like that, but then it is just simple dyselectrolytemia which has caused them to have a drowsiness, which can be corrected if treated appropriately.
So anyone wants to ask any question?
So before actually, I would like to elaborate. I would like to thank Dr. Ravi for an excellent presentation. He has covered a lot of things in a very sequential manner. For me, the thing is, what my nurses should be knowing about how to take a proper sample, because taking a proper sample is most important for anything. And I have found that the sample collection sometimes is not proper. Sometimes, as Dr. Ravi had clearly elaborated, the caps are not properly kept properly. The containers in which the sample is being sent to the lab is not done appropriately, and we might have some sort of wrong values. So one thing is an appropriate sample collection. Appropriate timely sample transfer to the lab is very, very important. The next thing is, once we get a proper report, we need to know what is the normal value of the report, and also we need to decipher what is the emergent action we have to do. Most of the times, thing is, sometimes the doctors might be a bit lazy or miss out on the labs. If as an ICU nurse or an ICU staff should be very alert for especially these red flag signs, especially high values, sodiums can be high, potassiums can be high. All these things we need to correct in an appropriate way. And in fact, most of the time it is the nursing staff who alert the doctors about this particular being out of range or not being normal. So that way it helps the patient, that way it helps improve the outcomes. So anybody would like to ask any questions can actually raise their hands, and then we can.
This is critical alert value which is being put across. Most of the hospital do have their own critical value. This is from our hospital, so where this is displayed in the ICU. Whenever the lab value goes above or below or some test, irrespective of the value, they're positive. So you have to alert the physician. So this is a critical alert, laboratory alert parameters which is being displayed.
Look, Ravi, I mean, maybe I think this is out of context, but then the thing is, you have actually put up a slide previously regarding the containers. I think a lot of hospitals do have this particular containers, in which container we need to actually send the sample. I think this one would be really good if you can actually tell me briefly about one or two words about what sample to be sent in which particular container. Yeah.
Yes. So here, what we are looking at is, the most important thing is, the blue top container which contains sodium citrate. So all your coagulation tests, your PT, APTT, INR, D-dimer, all these would be done with sodium citrate. And what you have to remember very clearly is, it has a fixed amount of sodium citrate, and you need to add fixed amount of blood to that. There is a, if you look at the Accutaner very clearly, there is a line drawn on the Accutaner. You have to fill to that level. You need not be, you should not be more than that or less than that, because it neutralizes and you are able to get the exact value. So that is very important when you're talking about sodium citrate container. The second is the EDTA Accutaner. Again, all your full blood count, your HbA1c and ESR, all this will be done on the EDTA. Basically, the EDTA will be sprayed on the Accutaner. You don't see anything, and it will preserve the morphology of the cells so that you will be able to put the sample in the automated analyzer, and you will be able to get the correct CBC values. The next one is the there are two other Accutaners which are noted. That is the Serum Accutaner, where you send all your calcium, ionized calcium, LDH, hormone levels, and all this will be done on the Serum Accutaner. Okay, and the other is the SST Accutaner, that is serum separator, where you will be doing your thyroid hormone levels, digoxin, all this will be done on the yellow Accutaner. And the other is a plasma separator. Plasma separator Accutaner does contain silica gel, which will activate the distinct clot and will help in formation of the plasma, where you want to test the plasma for your cardiac enzymes, protein, amylase, lipids, all this will be done on the green Accutaner. And again, your gray Accutaner, you want to send it for the blood glucose levels. So these are the different Accutaners which you will be doing, and pink Accutaner is for the blood transfusion samples. So there are some deviations. This is a standard one from the BD Accutaner system, but there are commercially different Accutaners available. But they do mention what is the anticoagulant or coagulant which is added to the Accutaner. It will be very clearly mentioned on the Accutaner itself. So you have to clearly see and send the appropriate sample. And as sir said, very important is, if you have accidentally taken a sample into a Accutaner, please never transfer that content into another Accutaner. Discard that sample.
think if there is no more discussion, anybody has any other questions to be asked, you can please ask here. Please raise your hands. You can actually discuss on the forum as well. Okay, I think there are no more questions. So let's close this session. I would like to tell a small story about the labs in an ICU and the role of the nursing staff in evaluation of a patient who is really bad. So the thing was, there was a lab report which was we were thinking our ABG lab were showing certain mistakes. So what happened was we were trying to see what happened to the patient who was having some sort of ECG changes. It was looking like a hyperkalemia, but the ABG was not fine. So we had sent a lab value. And one of our clinicians forgot about that particular lab value. The lab value had come. But then it was the nursing staff who actually immediately alerted us saying that, sir, the lab value is definitely on the higher side, but the ABG value is on the lower side. So, sir, probably because this patient is having ECG changes, you should consider this patient to be having hyperkalemia. And in that particular situation, we were able to save that particular patient, correct the patient's electrolyte abnormality. So here, I think there are a couple of things. Some people have asked questions about ABG, chest X-ray. Dr. Ravi, would you like to tell anything in brief about the chest X-ray, maybe in 1 minute or 2 minutes, so that it will be for completion?
Sure. So if you look at, there are multiple indications for X-ray as such, but I'm not going into in detail of that. I'm only going to look at what are the indications of X-ray in our ICU setting. So when do we need to do X-ray? So you do routinely and you do on demand. Routinely is, whenever you have a patient who is being admitted to the ICU with some respiratory symptom or, thoracic or extrathoracic disease or a cardiac history, or a patient who is on NIV or mechanical ventilator, you do at the time of admission. Then again, when do you repeat it? You repeat it whenever there is worsening of the clinical condition, like there could be hypoxia, there could be patient could be in respiratory distress, patient could be having hemoptysis, or a patient on a mechanical ventilator, you are suspecting some mechanical complications like pneumothorax, or the patient is becoming drowsy on the NIV and you are suspecting pneumonias, or the patient on a ventilator clinically worsening hypoxia, so you suspect ventilator-associated pneumonia. So these are the on-demand indications for doing an X-ray. Or you do a certain procedure, like you put a central line. So follow through, you do X-ray. There is, when you do it ultrasound guided, whether you do X-ray or not do X-ray, again, there are so many controversies. So for us in our ICU, we routinely do X-ray to look at the tip position. Or whenever you put a nasogastric tube, again, you have to do an X-ray to look at the position of the nasogastric tube, without which you cannot start feeding or give any medications to the patient. And whenever you put a ICD tube, or any procedure has been done, or a patient has undergone ventilatory support, and all these mechanical complications happen, pneumothorax developed, ICD or a pigtail has been put, or you have done a pleural effusion tapping. So post subsequent follow-up, you do X-ray. And patients who have invasive catheters like pulmonary catheter, you want to know the exact position of the tip of the pulmonary catheter, which you are not doing routinely in the ICU. But if pulmonary catheter is in place, definitely you do routine X-ray daily. Then I will not go into what is ABG. I'll just briefly summarize. So this is how typically your ABG looks like. The indications of the ABG, you have to look at either what is the oxygenation status or ventilation status of the patient. You want to look at the PO2 or the PCO2 value of the patient, or you want to look at the pH, the metabolic parameters, whether the patient is acidotic, alkalotic. So these parameters you want to look at, you do an ABG. So there are some values which are measured. Your pH, PCO2, PO2 are measured values. And there are some calculated data, the most important of which is the bicarbonate, which is calculated actually. And there is some data which you need to enter before doing the sample. Like you have to enter the temperature, you have to enter the hemoglobin value of the patient. But most of the machines, ABG machines, do have hemoglobin, which will give us a value. And the most important parameter which we don't enter in the ABG machine is the effort of the patient. So whenever you are asked to enter the FiO2, please do enter the FiO2 of the patient whenever you are loading the ABG. So there are different indications of ABG. Rather than that, I'll concentrate on how to evaluate the ABG. So if you want to look at, this is how a normal ABG looks like. The pH is between 7.35 to 7.45, and the PCO2 is between 35 to 45. This is a normal value. Take it as 40, an average, and 7.4 is a normal value. PO2 on room air, it is between 80 to 100. Bicarbonate is 22 to 26. The average is around 24. So if you remember the normal values, then you will understand what is abnormal. Then, so for us to understand whether the patient is acidotic or alkalotic, first you have to look at the pH. The pH falling less than 7.4 is acidosis. pH going more than 7.4 is alkalosis. So how do you define this? Is by the Henderson-Hasselbalch equation. If you simplify the Henderson-Hasselbalch equation, you get the simplified formula that is nothing but pH is equal to pK plus log of bicarb by PCO2. So you remember bicarb is at the denominator and PCO2 is the denominator. So if the bicarbonate is increasing because it is in the numerator, the pH increases. It is directly proportional. The PCO2, the percentage of carbon dioxide, what you are going to measure is in the denominator position. So it is inversely proportional to the pH. So if the PCO2 is increasing, your pH drops. If the PCO2 is decreasing, your pH increases. So as we have seen, any condition which increases the pH is called alkalosis. So alkalosis can happen because of two reasons. Either because the bicarbonate, which is the numerator, can go up, which is the metabolic component, which is called metabolic alkalosis. The other component is the respiratory component, where the PCO2 can be washed out and the PCO2 goes low, because of which the pH increases. Because PCO2 is in the denominator, it is called respiratory alkalosis. Exactly inverted. The pH is going down, it is acidosis. Since the pH is going down, the bicarb also is going down, that is called metabolic acidosis because it is the numerator. And if it is respiratory acidosis, the PCO2 should increase because it is the denominator. So there are four essential basic disorders which are possible. That is metabolic acidosis, metabolic alkalosis, respiratory acidosis, respiratory alkalosis. So if you look at pH increasing, okay, that is called alkalosis. If it is because of fall in PCO2, it is called respiratory alkalosis, where the bicarb can be normal. Okay. The other is the pH going down and the PCO2 going up. Denominator is increasing, so the pH is dropping. So it is called respiratory acidosis. And metabolic alkalosis is pH increasing, bicarb increasing. Metabolic acidosis, pH dropping, bicarb also dropping. Then you have to look at the compensation mechanism. Since the primary disorder is metabolic acidosis, to maintain the pH within the normal range, if the numerator is falling, the denominator also will try to go down so that the ratio remains constant, so that the pH remains within the normal value. This is called compensatory mechanism. If the primary disorder is metabolic acidosis, the compensatory mechanism is respiratory alkalosis. On the other hand, for metabolic alkalosis, if the primary disorder is metabolic alkalosis, the secondary disorder is respiratory acidosis. So this is a compensatory mechanism, what I am talking about. If you look at the compensatory mechanism, the pH going down, metabolic acidosis, bicarb going down, so the PCO2 also goes down, that is called respiratory alkalosis. Metabolic alkalosis, pH going up, bicarb going up, so the PCO2 should also go up. So that is causing respiratory acidosis. On the counter side, the respiratory acidosis, PCO2 is increasing, pH is dropping, the compensatory response is metabolic alkalosis. Respiratory alkalosis, pH is going, pH is going high, the PCO2 is washed out, PCO2 is going low, so the bicarb also goes low. So it is compensatory mechanism, this metabolic acidosis. So to simplify this, if you have an ABG, first look at the pH. Is the pH less than 7.4? Then it is acidosis. If the pH is more than 7.4, it is alkalosis. If it is acidosis, look at whether it is metabolic or respiratory. How do you tell it is metabolic? If the bicarb is falling less than 24, it is metabolic. So in the compensatory mechanism, what you are expecting is respiratory alkalosis. On the other side, if the bicarb is normal, if it is because of the rise in PCO2, then it is called respiratory acidosis. The compensatory mechanism is metabolic alkalosis. On the other side, if the pH is more than 7.4, it is called alkalosis. If it is because of rise in bicarb, it is called metabolic alkalosis, and the compensatory mechanism is respiratory acidosis. And if the alkalosis is because of rise in fall in PCO2, then it is respiratory alkalosis. Then the compensatory mechanism is the bicarb also tends to fall, which is metabolic acidosis. So this is how we have to interpret the AB. This is simplified. There are, again, partially compensated, fully compensated, mixed disorders, which we are not going to discuss. If you are able to judge whether the patient is acidotic or alkalotic and what is the primary disorder, that is more than enough for your understanding.
A couple of things which I would like to add is, especially regarding the chest X-rays, I would like all my nursing staff to know whenever we have placed a Ryle's tube, they should always confirm with an X-ray. See, they should know the tip. They should always trace the tip of the esophagus to the stomach, because sometimes, we have saved, we might think that, okay, though we have that gush of air coming, that sound coming, we have confirmed the tube position, the Ryle's tube position, but sometimes it is wrong. We might not be in the correct position. You should always get it confirmed by an X-ray, especially the Ryle's tube, the endotracheal tubes, and all these things have to be confirmed. The central lines, all this have to be confirmed by the imaging. And the nursing staff should know whether this is in position or not, or there is any deviation from the normal. And with that, I think we are already out of time. But at the final stages, I would like to just thank all the organizers of this particular STEP-IN program, which is a really successful nursing training program. Also, I would like to thank Dr. Ravi Sankar for doing an elaborate presentation, exclusive examples. Seriously, I'm really impressed by the way he had presented all the things in a very, very simple and lucid manner. Also, I would like to thank all the people who had come. I know you're all really busy at this point of time, 3 o'clock. Maybe it might be your shift time, or expect of maybe you're a post duty or something. You might be really busy, but the thirst for knowledge has made you come to this particular level. I really hope you guys had enjoyed this particular session. Also, you should come again and again for this particular repeated STEP-IN sessions, so that our knowledge can be improved. So with that, I would like to close this particular meeting. Dr. Ravi, any closing remarks you'd like to make?
Nothing good. Thank you. Thank you for moderating the session, sir. And thanks, ISSM, for giving me this opportunity.
Thank you, ISSM, once again. With this, I would be closing the session. Mr. Dawal, it's done.